reflexes and the abdominal reflexes. In some cases, we might do cremasteric reflexes, corneal reflexes, and conjunctival reflexes. And in other cases, we might do gluteal reflexes. But in routine examinations, we usually examine the plantar reflexes and the abdominal reflexes only. Examination of the plantar reflex is done as follows. We hold the patient's foot at the ankle and we stroke the lateral side of the sole of the foot in a forward direction like this, and notice plantar flexion of the toes. We repeat the reflex on the other side in the same manner. Stroking of the sole of the foot is done by the handle of the hammer or by a key. This method of eliciting the plantar response is known as the Beniski method. There are other methods of eliciting the plantar response. Examples of such methods are the following. Oppenheim method. Oppenheim method is done by stroking the medial aspect of the tibia with the thumb in a downward direction this way. The next method is the so-called Gordon method is done by squeezing the calf muscle this way. The next method of eliciting the plantar response is the so-called Schieffer method, which is done by pinching the tendo Achilles, and we repeat it on the other side this way. Yes. The next method of eliciting the plantar response is the so-called Shaduk method. Shaduk method is done by stroking the lateral side of the foot below the lateral malleolus. Stroking the lateral side of the foot below the lateral malleolus. The next method of eliciting the plantar response is the so-called Gonda method, which is done by pressing down the fourth toe. And we repeat it on the opposite side like this. Then we proceed to examination of the abdominal reflexes. The abdominal reflexes include the following: the epigastric reflexes, the upper abdominal reflexes, and the lower abdominal reflexes. Abdominal reflexes are elicited by stroking the abdomen from outward towards the midline this way, and we compare both sides together. And we should elicit the epigastric reflexes, the upper abdominal reflexes, and the lower abdominal reflexes. Stroking of the abdominal wall induces contraction of the abdominal muscles on the same side with shift of the umbilicus towards the side of the stimulus. In pyramidal tract lesions, usually abdominal reflexes are either diminished or absent on the same side of the lesion. In some cases, we examine for evidence of pathological reflexes. The commonest pathological reflexes elicited in such cases are the following. The so-called sucking reflex. Sucking reflex is done by touching the angle of the mouth with the finger or with the handle of the hammer, for example. This induces a sucking movement if this reflex is positive. The reflex is positive in infants during the first year of life and in patients with diffuse lesions of the brain, particularly involving the premotor cortex. The next pathological reflex is the so-called snout reflex. Snout reflex is done by tapping the upper lip of the patient and observing the bounty. This reflex is also positive in the same conditions as the sucking reflex. The next pathological reflex is the so-called grasp reflex. Grasp reflex is done by touching the palm of the patient with the index and middle fingers of the examiner and moving them towards the tips of the patient's fingers. If the grasp reflex is positive, strong flexion of the fingers occur and the patient grasps the examiner's fingers. This reflex is positive in infants during the first year of life and in patients with diffuse cerebral lesion, particularly affecting the frontal lobes. The next pathological reflex is the so-called grouping reflex. Grouping reflex is done by stimulating the side of the patient's palm and we notice that patients with positive grouping reflex follow the examiner's hand and trying to catch it. This reflex is also positive in the same conditions as those with positive grasp reflex, sucking reflex, and snout reflex. Let me shift to examine coordination. Coordination is examined by the following tests. The so-called finger-to-nose test, which is done by asking the patient to extend his upper limb horizontally and to touch the tip of the nose with the tip of the index finger like this. And we observe any evidence of kinetic or intention tremors. And we repeat the test on the opposite side. The next test for coordination is the so-called finger-to-finger test. Finger-to-finger test is done by asking the patient to extend his upper limbs horizontally and try to touch the tip of one of the index fingers with the tip of the index finger of the other hand. And we observe any evidence of intention tremors. The next test for coordination is the finger-to-nose-to-finger test. We ask the patient to horizontally extend his upper limb, then to touch the tip of his nose, and then to touch the tip of the index finger of the examiner. We take it. This is known as finger to nose to finger test, and we repeat the test on the opposite side. And we observe any evidence of intention tremors. We should repeat finger to nose test and finger to finger test with patient's eyes closed, so as to differentiate between cerebellar ataxia and sensory ataxia. In cases of cerebellar ataxia, intention tremors occur whether the patient's eyes are closed or open, whereas in sensory ataxia, intention tremors appear only on closure of the eyes. The next test for coordination is the so-called heel-to-knee test. Heel-to-knee test is done by asking the patient to raise one of his lower limbs and to touch the knee of the opposite leg with the heel of the raised leg, and to move the heel on the medial aspect of the tibia in a downward direction this way. And we observe in evidence of intention tremors during this procedure. We repeat the test on the opposite side. In cerebellar ataxia, intention tremors occur on doing this test, however the patient's eyes are open or closed. Whereas in cases of sensory ataxia, such as tabes dorsalis, intention tremors only appear on closure of eyes. The next test for coordination is the so-called rebound phenomenon. Rebound phenomenon is done by asking the patient to flex his upper limb at the elbow against resistance. And we suddenly release the upper limb and notice any rebound movement. In cerebellar ataxia, the patient cannot check the rebound movement of his upper limb on sudden releasing of the limb during flexion. So the examiner should put his left hand in front of the patient's face to protect it from being stroked by the upper limb of the patient on sudden release. The next test for coordination is the so-called adiadochokinesis or dysdiadochokinesis. Adiadochokinesis or dysdiadochokinesis means the inability to carry out alternate successive movements such as repeated supination and pronation of the hands and forearms. We ask the patient to alternately supinate and pronate his forearms and hands, and we observe the smoothness of movement. In cerebellar ataxia, such alternate rapid successive movement is usually slow and clumsy. We will proceed then to examination of the sensory system. Examination of the sensory system includes examination of the superficial sensations, examination of the deep sensations, and examination of the cortical sensations. Examination of the superficial sensations includes the following: examination of the